It's my pleasure to be hosting the CITM Journal Club through our Johns Hopkins Armstrong Institute Center for Diagnostic Excellence. The program has been hosted in the past couple of years through the center at the Houston VA, run by Hardeep Singh, and focused on patient safety and quality, along with Ashley Meyer and others there who've done an amazing job, and we appreciate all their hard work that over the past couple of years, and we're going to pick up the baton here. So just to remind everybody, our goals here obviously are to generate novel discussions related to diagnosis and diagnostic error, to breed scholarship, academic development, ideas for new research, promote collaboration. And the overall format that we've used for the Journal Club is to have an invited speaker who gives a brief presentation, 15 or 20 minutes or so, about some of their work that's ongoing. And then to have open discussion thereafter to give people a chance to ask questions directly of an investigator, and for us to get to know each other a little bit better and to learn from one another. I'd like to introduce Dr. Marcio Melo, who's a psychiatrist and physician researcher at the University of Sao Paulo in Brazil. And I've had the great pleasure of meeting him in person and having some wonderful conversations about the neuroscience of decision making. He does amazing work with fMRI around diagnostic decision making, and he's going to talk to us about that now for the next 15 or 20 minutes, and then I look forward to a robust discussion thereafter. So with that, I'd like to hand it over to Dr. Melo.
Thank you, David. Thank you for the opportunity to present my study in this forum and for your kind presentation. Understanding the brain mechanisms involved in medical tasks such as diagnosis of diseases and prescription of treatments may contribute to reveal causes of medical errors. I divide this presentation in three parts. In the first one, I will briefly present the conceptual framework that informed our research. In the second part, I will present a summary of our fMRI investigation of radiological diagnosis, which is an introduction to the main part, which is our last study when we investigated how doctors diagnose diseases and prescribe treatments with primary care physicians. We conceptualize diagnosing as a lexical semantic associative process. What does this mean? When you see this picture, immediately the word jaundice comes to your mind. Jaundice is associated with a yellowish sclera and skin. The semantics of the word jaundice is its meaning, a pathological yellowish sclera and skin. Jaundice is the word, the lexical representation that refers to a pathological yellowish sclera and skin. Jaundice is the lexical semantic representation of a pathological yellowish sclera and skin. But you may also hear or read the word jaundice. Just reading or hearing the word may evoke diagnoses related to it, such as hepatitis. And this occurs also through a lexical semantic associative process. If your patient has alcoholism, this creates a context in which jaundice possibly will evoke the diagnosis of cirrhosis. When a physician detects a symptom, information related to it is automatically activated through a lexical-semantic associative process. For example, the word here we have in this slide possible differential diagnosis evoked by jaundice. It depends how the knowledge of the physician. It depends on the context, so this is a very crude representation of a lexical semantic network of differential diagnosis evoked by jaundice. Information related to diseases is also organized in lexical semantic networks: symptoms, risk factors, treatments, differential diagnosis, etc. When you evoke the diagnosis of a disease, the lexical semantic network of information related to it is automatically activated. Let's see in more detail the lexical semantic network associated with hepatitis B. Here, again, we have a very schematic network of informations related to hepatitis B. And the content of this network also depends on the knowledge and the experience of the physician with this disease. There are several models of how lexical semantic information is organized in the brain. In the medical domain, illness script is one of these conceptual models. Concluding this section, diagnostic reasoning is instantiated in the lexical semantic domain. The words, their meanings, and the associations between them. The culmination of the diagnostic process, the diagnosis itself, evocation of the name of a disease, is realized in the language domain. This conceptualization enabled anatomofunctional predictions regarding brain mechanisms involved in diagnosis. So let's now go to the summary of our fMRI study of radiological diagnosis. Our main hypothesis was that diagnosing diseases and naming things in everyday life involve similar brain networks. The experimental design, the main task of the experimental design was the diagnosis of radiological lesions by radiologists. The image of a chest X-ray with a radiological lesion was projected while the radiologist was inside the scanner, and he or she was asked to verbalize the diagnosis as soon as it came to their minds. As a comparative task, he was asked to name animals that were inserted also in chest X-rays. Images were presented for 1.5 seconds, and there was an additional 2 seconds period for responses. These are the main results, the main fMRI results, in which you can see that the overall pattern of activations was similar in both tasks. There was greater activation in occipitotemporal areas while naming animals as compared to diagnosing lesions. This result this difference results from the greater visual complexity of animals as compared to radiological lesions. But when you observe frontotemporal areas involved in lexical semantic processing, the similarity in both tasks is striking, supporting our hypothesis. The mean response times show that diagnosing based on visual data may be very fast. Diagnosing disease, the mean response time for diagnosing disease was 1.3 seconds, and naming animals 1.2 seconds. Interestingly, 72% of the participants reported cogitating differential diagnosis at least once during tasks. Okay, let's now go to the main part of this presentation, our study with primary care physicians. There were two experiments in this investigation. In the first one, a sequence of information created to evoke a target diagnosis was presented sequentially following this time frame. In this sequence, the target diagnosis was pneumonia. And there was unspecific symptoms such as high fever or a highly diagnostic information such as pulmonary condensation. The comparison task in this experiment was naming animals and objects using the same format, sequences of information with different levels of diagnosticity. The second experiment was the task to verbalize the treatment related to the disease that was presented. In this case, we expected the response penicillin, a treatment for syphilis. The first hypothesis was that diagnosing diseases, prescribing treatments, and naming animals and objects involve similar brain systems based on written information. This hypothesis implies that prescription of treatments also involves a lexical semantic associative process. And here you can see the striking similarity between brain activations in the three tasks. The mean response times in sequences beginning with highly diagnostic information was 3.1 seconds and 4.1 seconds in sequences beginning with unspecific information. Also, 80% of participants responded with differential diagnosis at least once. For example, one participant in a sequence with cirrhosis is a target diagnosis, responded hepatitis and afterwards cirrhosis. The next hypothesis, the results that I will present you, demanded greater temporal resolution in the analysis, which we got through mathematical modeling of the fMRI acquisition parameters. So the following results were based on analysis of time periods of 400 milliseconds. Our second hypothesis was that unspecific symptoms elicit greater activity in brain attentional areas as compared to highly diagnostic information. Here you can see that when the first information had high diagnosticity, there was a decrease of activation in frontoparietal areas involved in attentional monitoring as compared to the previous period when the task was simulated. When you have low diagnosticity, the first information was of low diagnosticity, the level of activity in the frontoparietal attentional network remained at the same level. We proposed that the decrease of activity in brain attentional areas associated to highly diagnostic information is related to a reduction of uncertainty regarding the final diagnosis. Our third hypothesis was that decrease of activity in the frontoparietal attentional network contributes to trigger decision making. And here you can see that in the decisional period, immediately before of the point of responding, there was deactivation of the frontoparietal attentional network. We hypothesize that decrease of activity in this network indicates reduction of uncertainty regarding the final diagnosis and may function as a signal to end the diagnostic investigation, which is necessary in a diagnostic investigation. At some point, the doctor needs to say enough and concludes the investigation. However, highly diagnostic information in this context may precipitate premature diagnostic closure because highly diagnostic information decreasing activity in the frontoparietal attentional network may precipitate the trigger of decision making. That is a mechanism that is usually necessary and important for the efficiency of a diagnostic investigation, sometimes may go awry and precipitate premature diagnostic closure. And highly diagnostic information may be a cause of this malfunctioning. There was an unexpected finding. We observed a large-scale shift of brain activity in areas involved in awareness and auditory monitoring at the point of responding. When you compare the decisional period and the point of the response, the beginning of the vocalization. Our interpretation of the previous result is that we think that this epoch, maybe in this epoch, physicians, participants in the experiment, were becoming aware of the responses they made. Because this would fit the pattern, the sharp, the dramatic change we saw in this period of time. Again, we are analyzing time periods of 400 milliseconds. It has been proposed that we need to hear ourselves, aloud or silently, to become aware of our own thoughts. Thank you.
Well, that's great. Thank you, Marcio. Fantastic presentation. Vanessa, have you seen any questions in the chat box?
No, I don't have any questions, David.
All right. Well, let's see if we can, Mehdi, can we just open up the the lines and just see if there are people who would like to speak up and ask questions?
I think people can unmute themselves and ask questions.
I see. Individually, so they're allowed to do it on their own. Great. So,
okay.
Do we have any questions from the audience?
Hi, this is Kathy McDonald. Can you hear me?
Hi, Kathy.
Hey, great. Yeah, I really enjoyed the presentation as well. I'm listening, and I had read the paper, so I didn't get to see visuals during the presentation, but saw the paper. And I was curious about kind of the variability from person to person and what that might mean for some of the findings that you had, and thinking about the future work that you might do.
Okay, interesting question. The tasks were very stereotypical, so to decrease inter-individual variability. And because the signal, the bold signal that reflects brain activations is there is a small change that you capture during fMRI studies. So if there is great variability between individuals, you won't detect activations. They would because the bold signal depends on an average difference between the task and the control condition. So the tasks were planned to be highly stereotypical to increase the signal to noise ratio. Does it make sense to you?
Kathy, did we lose you? I don't know if we lost Kathy or if she just got muted.
Okay.
So other questions from the group? While people load up their questions, I'll ask a couple here that I've been wondering about. So Marcio, the one relates to the question that you just answered, which is essentially you made these cases easy. That is that the associations were relatively simple and that response times were remarkably fast. Do you have any guesses as to what things would look like if you made the tasks hard, number one? And number two, how do you see that relating to the dual process theory of clinical reasoning with system 1 and system 2 type thinking?
Okay, the two questions are very interesting. Well, in our present project, we are making tasks harder. While we are investigating differential diagnosis in our present project, and we expect, as we discussed, greater activation of brain areas involved in conflict monitoring and attentional mechanisms. But my hypothesis is that which we will test in this in the present project on differential diagnosis, is that there are not two systems. There is just one system that is modulated by the task difficulty. And this is something that is testable, and our experimental design is planned to assess this possibility, this hypothesis. Okay, Richard has a question that we are addressing in this project on differential diagnosis. And when an information, an unexpected information makes the diagnosis less certain, I think there will be recruitment of attentional mechanisms and greater activity in conflict monitoring. But this is not necessarily a new system, because, for example, when you see when you detect high fever, automatically there are several hypotheses that come to your mind, and this is the reason that we have greater activity in the frontoparietal attentional networks. What we are planning in the present project on differential diagnosis is just to answer your question, Richard, which we are introducing contradictory information to increase uncertainty about the diagnosis. And we have some hypotheses of what to expect. But presently, the only thing that we can affirm with certainty is that unspecific symptoms evoke greater attentional activity as compared to highly diagnostic information.
This is Dave Newman-Toker. Could I ask a follow-up to that question? So, do you think that there's a directional bias here, or is the level of uncertainty in any given piece of information a commutative? And what I mean by that is, essentially, if you had one piece of information that had 50% specificity, and another piece of, and you sent it through in the positive direction before someone had decided, and it flipped them over to the other end, and then you did the same thing when they were already flipped to see whether it would flip them back. In other words, is there some way to test whether it's easier to get to a decision than to undo a decision?
Oh, this is an interesting question. I don't have a response for you, but what we observed in the behavioral results is that when there were situations in which the physician changed her response, he gave a response and changed her mind and gave another response. So in a certain sense, she was correcting herself. This is, but our experimental design was not planned to investigate the neural substrate of this correction. But this is something that we observed. In the correction, I think that the correction occurred after the doctor became aware of her response. So, to correct an error, first, the doctor needs to hear his or her response, to become conscious of her response. But this is something that there are fMRI studies using much simpler tasks, investigating error corrections, but these are tasks much more, much simpler than the ones we are employing. So we are in a very initial stage of the investigation of brain mechanisms involved in diagnostic reasoning. For example, there is no study adequately, properly planned to investigate if there is one or two systems. And while if there are two systems, when system 2 is recruited, this is something that we're planning to test in the differential diagnosis project.
Great. Other questions?
Okay, Ashley, your question is very important. That
so could you either read us the question or Ashley speak it out loud? Because I don't see it
his
here.
Microphone.
Oh, there it is. Okay, got it.
It's not working.
I see.
Is it working now?
Yeah.
Okay.
You got it.
Oh, good. Okay, I've been hitting lots of buttons. Okay, so I was curious. This is really interesting. Thank you so much for the presentation. I was wondering so there's work showing that physicians aren't always aware of how uncertain they are, at least explicitly. Do you think these findings related to the FPAN, the frontoparietal network, could be used to train physicians about their uncertainty, maybe using some kind of biofeedback, maybe to improve their metacognition around their uncertainty?
Oh, okay.
Maybe that's a long question, sorry.
Yes, okay. Your question is very pertinent because there is a heated discussion about the effectiveness of methods to train physicians to reason better versus methods to improve the knowledge of the knowledge organization. And there are many studies, but several studies showing that physicians, when physicians err, they are not aware of their errors. And in general, they are overconfident about their diagnostic skills. But I think that fMRI or biofeedback are very clumsy methods to very clumsy and expensive methods to improve metacognition in. And I really have. I'm very. The experimental data doesn't clearly show up to now that it's possible to improve generically reasoning skills. What is while there is strong evidence that what is very determinant of diagnostic skill is knowledge, and how the doctor organize the knowledge in her or his brain. And so I hope to have answered your question.
Yeah, no, that's a great answer. Thank you.
Other questions?
I have another question if no one else wants to chime in. This is Ashley.
Go for it, Ashley.
Do you know, I'm not sure how big the sample size was or if this would be feasible to do on fMRI because you might need more subjects. But do you have a sense that there are differences in expertise as far as how much the brain activity during diagnosis and treatment decisions matches everyday naming of objects? I was just wondering because it seems like the more expert you are at that, the more it would match, you know, like the everyday things that you're used to doing all the time. And so maybe more novice physicians, maybe their network of activity would look different, maybe. Do you have data on that or even just thoughts about what that might look like?
Yeah. Yes, this is a problem that in these two studies we explicitly avoided because expertise would be a confound variable. So we used tasks aimed at assailing performance, easy tasks. So expertise won't be a confounding variable. But our data is not appropriate to make to have conclusions or to think about expertise, because we try to avoid this. In general, the fMRI studies, for example, with chess masters, comparing with known experts in chess, in general, there is greater activation when you are a novice, as compared with an expert. In chess, this is something that has been already investigated, but not in the medical. There are studies trying to relate fMRI studies, published fMRI studies, trying to relate expertise with brain activation, but their experimental design was very problematic here. And I think that they are not properly designed to assess expertise.
Gotcha. Okay, that's really interesting. Thank you.
You're welcome.
All right. Any final questions or thoughts for Dr. Melo? Well, hearing none, I'll thank everybody for your attendance. I'll do what Vanessa reminded me to do, but I forgot to do, which is introduce myself. I'm David Newman-Toka, the Director of the Center for Diagnostic Excellence at Johns Hopkins. Thanks everybody for being here. Thank you especially to Dr. Melo for his excellent presentation and answers to our questions. And we look forward to seeing everybody, hearing everybody at the next Journal Club, and hopefully seeing you in person at the next Diagnostic Care and Medicine meeting in New Orleans next November. So have a great day, everybody, and we'll look forward to talking again in February.
You. Thank you, Dave.
You're welcome.
Thank you, everyone.
Bye-bye.
And thank you for all.
Bye. Thank you.